let's talk about one of the highest stakes balancing acts in all of inpatient medicine, managing severe hyponatremia. For decades, the mantra has been simple: go slow. But what if that caution, the very thing designed to prevent a devastating complication, is actually causing more harm than good? Well, this has sparked a massive debate, pitting decades of wisdom against some really provocative new evidence. We're going to break it all down.
So this is really the heart of the matter, isn't it? This is the one question that splits expert opinion right down the middle. It puts the fear of a catastrophic iatrogenic injury, an injury we cause with our treatment, against the immediate dangers of the low sodium itself.
And this slide, wow, this really lays out the tightrope we have to walk. If you correct too slowly, you're risking ongoing cerebral edema, seizures, even brain herniation. But if you correct too fast, you can trigger something called osmotic demyelination syndrome, or ODS, which is a truly devastating neurological injury. We're talking paralysis, coma, even death. So no matter which way you go, there are potential dangers. To really get our heads around this, here's how we'll tackle it. First, we'll look at the bedrock of our current practice, the doctrine of slow correction. Then, we'll get to the challenger, this major new study that's questioning everything. We'll hear the powerful rebuttal from the old guard, check out some of the advanced tools we have now, and finally, try to pull it all together into a practical approach for navigating this clinical minefield. All right, let's start at the beginning. Why did slow and steady become the undisputed rule for so many years? Well, it all goes back to a series of landmark findings that showed us just how terrifying ODS could be. The story really builds piece by piece. Back in the early 80s, animal studies were the first to connect rapid correction to these awful brain lesions. Then by 86, we got the term ODS, which focused on what was actually happening to the patient. But the real bombshell? That came in 1987, with a study that showed pretty clearly that patients corrected by more than 12 in 24 hours were the ones getting ODS. All of this evidence eventually led to the 2013 and 2014 guidelines, which basically cemented these cautious limits into our daily practice. Now, what's really interesting here is how specific these guidelines got. You can see both the US and European panels landed on a 24-hour limit of around 10. But look at that crucial line for high-risk patients. People with super low sodium, alcoholism, liver disease. For them, the limit is even tighter, no more than 8 in 24 hours. These numbers have basically been our gospel for a decade. But what if this whole doctrine, built to prevent a rare event, has an unintended and maybe more common dark side? This is where our story takes a really dramatic turn, with new evidence that throws a wrench in everything we thought we knew. In 2024, the debate wasn't just reopened, it was blown wide open. A massive systematic review and meta-analysis gets published in JAMA Internal Medicine, and it basically throws a grenade into the middle of the room, questioning that core assumption that slower is always safer. And the reason this study made such huge waves? It really comes down to its sheer scale. This wasn't some small case series. We're talking about an analysis of data from over 11,000 hospitalized adults with severe hyponatremia. The statistical power here is just undeniable. And the findings? They were absolutely striking. Compared to a slower correction, a faster rate, right at that 8 to 10 guideline limit, was associated with 32 fewer in-hospital deaths per 1,000 patients. At 30 days, that number jumped to 61 fewer deaths. And maybe the biggest bombshell of all, they found no statistically significant increase in the risk of ODS. The implication is profound, right? Are we trading away lower mortality to avoid a risk that might be smaller than we think? Well, as you can imagine, this did not go unchallenged. An international group of experts, many of whom actually helped write the original guidelines, quickly published a powerful rebuttal. Their message was clear. It is way too soon to abandon decades of hard-won caution. In this quote, this just perfectly captures their position. They're basically saying the reason ODS is rare now is because we all follow the guidelines. So to them, ditching the guidelines based on this new data would be a huge mistake. It's like throwing away the very thing that's been keeping patients safe all along. And their argument isn't just a philosophical one. They went straight for the study's methods. They point out that relying on old billing codes to diagnose something as complex as ODS is just not reliable. And this is critical. ODS symptoms are often delayed by days, and the MRI changes can take weeks to show up. That means the study could have just missed a ton of cases. Their conclusion? The study simply wasn't designed to reliably detect the very complication it claims isn't increased. Okay, so we're caught between two really compelling arguments. While the experts debate the data, what tools do we actually have at the bedside to navigate all this uncertainty? Well, this brings us to a really key class of drugs, the vasopressin receptor antagonists, or VRAs. In a nutshell, these drugs, like tolvaptan, directly fight the hormone that causes water retention in a lot of hyponatremia cases. By blocking vasopressin's action in the kidney, they make the body excrete free water, which in turn directly raises the serum sodium.
And this case shows you both their power and their peril perfectly. A patient with SIADH gets tolvaptan, and boom, their sodium shoots up from 112 to 123 in just a few hours. But look at step 5. This is the whole ballgame right here. The team has to actively jump in with a D5W drip to slam on the brakes and stop from overshooting the safe limits. So yeah, VARAs give you control, but they demand constant vigilance.
And these are absolutely not a one-size-fits-all magic bullet. I mean, using a VRA in a hypovolemic patient is just dangerous. You could make them even more volume depleted. And they don't really work in states where vasopressin isn't the main problem, like primary polydipsia. Honestly, knowing when not to use these drugs is just as important as knowing when to pull the trigger.
Okay, so how do we bring all this together at the bedside? We've got our established guidelines, a provocative new challenge, and a really strong expert rebuttal. Let's try to synthesize this into a practical framework for making decisions in the real world.
You know, this is probably the single most important takeaway. The goal isn't to just blindly follow a number, whether it's 8 or 10 or 12. The real art of medicine here is looking at your individual patient, assessing their specific risk profile, and tailoring the therapy to them.
So, where does that leave us? First, we have to respect the guidelines. They were created to stop a real, devastating injury. Second, while the new mortality data is important to think about, we can't just ignore the serious methodological critiques. This means those individual risk factors, a sodium below 105, a history of alcoholism, those have to remain our primary guides. And finally, we always have to be humble enough to know that the patient's underlying problem can resolve suddenly, causing us to overshoot our goal. That's why conservative targets and checking the sodium frequently are still our best defense.
And that leaves us with the central question for every single one of us managing these complex patients. Does this new mortality data mean we should be more aggressive, pushing closer to that 10 millimole limit? Or is that umbrella of caution, as the experts call it, the very thing that made this devastating complication so rare in the first place? It's a question that, for now, demands our constant attention, more research, and our absolute best clinical judgment.